of some percentage, or for if it is a healthcare professional, we can incentivize in form of kind, like on 26 January or 15 August in front of the whole institute, we can give a certificate of appreciation. If a student is reporting, we can incentivize in the form of giving marks, like you will get 2 marks extra for reporting more ADR. We will, like if at present, sir, if we say ki you have to report ADR, so if a patient is having an PPI, we can put a hoarding ki if you are taking PPI and you are having upper respiratory tract infection, you may please report to this number. Thank you. Thank you, sir.
Good morning, judges. My topic for the presentation is medication safety strategies and interventions. Is a review and future directions. So, as we know, medication error and medication safety are the global concern in the healthcare. And out of 10, one patients, it's WHO reported, one out of 10, one patient's 6 medication safety interventions or strategies was given in the my research. So first one was education programs, medication information services, the role of pharmacist, the training and the system design in the institutes, and the computer automation or double checkings. So yes, like 1 minute past. So to conclude it, like medication safety is a very critical in the healthcare settings, and it's a multi-sectoral, you can say, approach need to be done. So all these 6 if any new approaches is also there, that should be incorporated. It's not single approach which we can avoid these medication errors. So
what are the 6 approaches we are using?
So 6 approaches which I have received from the research. That's also is one of the approaches for reducing this medication errors.
Which medication safety strategy worked best?
Yes, sir.
Of all this?
Yes, sir.
Which medication safety strategy worked best?
So, sir, that's the thing that it was, because I haven't done meta-analysis type. So I have just picked up how I have not. You can say I have not done a quantitative study, so I can't give a percentage which ones. Because my stream is I am from hospital administration. My approach, which approach are like what I have find that single approach will not work. एक चीज़ कर रहे हैं तो net we want multiple approaches for this medication safety approach. So, but as a if for answering you, I will say that the most effective is education part. If we educate our healthcare workers, they will surely report.
Okay. Thank you. You want to ask something?
So error is like after another thing, yes, sir. So medication safety is like it's a primary branch of patient safety, and we is before occurring any error, we used to take interventions or any plans that before medication error.
Okay. Thank you so much.
Very good morning to respected judges and delegates. So the topic of my presentation is safety profile of anti-epileptic drugs, a pharmacovigilance perspective. As we know that epilepsy is one of the major CNS disorder and accounts for around 1% of the global burden of the disease. And due to the narrow therapeutic index of the anti-epileptic drugs, we are concerned about the long-term use of the drugs. So the CDSU recently in February 2022 has issued the safety alert regarding these anti-epileptic drugs. So we aim other related to the CNS ADRs, there were tremors, drowsiness, headache and dizziness. And for the the discussion, I would say that most of the ADRs were from the CNS, and most common was sleep disorder, and the most common offending drug was sodium valproate, followed by phenytoin and carbamazepine. And to conclude, I would say that extensive pharmacovigilance is further needed for the anti-epileptic drugs like sodium valproate and phenytoin, etc., because of their narrow therapeutic index, and recently safety alerts has been issued. So for to guide the physicians for better clinical outcome and for prevention of irrational prescribing. These are my references. Thank you.
Okay, so did you find out any new adverse drug reaction?
Sir, not new, but sir, there was recent safety alert of this phenytoin and carbamazepine to have been reported with the DRESS syndrome and Stevenson-Johnson. So that we found, sir, similar ADRs in our
As
center.
per previous reports.
As per previous.
What was the reason?
Sir, I said that mostly reports were from the male patients.
Yeah.
I think that is because of most of the drugs were reported to the male patients. Most of the drugs were prescribed to the male patients. So there is a male patient representation is more in our OPDs, sir. I think this can be the reason.
So how many were males and how many were females?
Sir, out of 100, there were 61% male ADRs reported, and 39% were from the females.
And how did you do the sampling actually?
Sir, these were all
What kind of
old ADRs reported at our center from July 2019 to December 2022. So we go through them all and then assess them. And
So was it consecutive sampling or was it like some other
it
type
was a
of
retrospective study, sir.
retrospective
Yes,
study?
sir. And we assessed the 4,200 ADRs, and out of which 100 were found to be anti-epileptic drugs. And then we do the causality, sir.
So you included all records during that
Sir,
period?
we
Or you excluded any records?
Morning, judges. This is my case report. This is of the DPR, direct patient reporting of suspected regression. This is the mainly is a review article. I review all the articles from the source of PubMed, eBase, and the libraries. The main aims and objectives are to see the pros and the cons of the ADRs, and in the result, I can see that what is there. What can be aware for that results, and the main discussion is how can we improve the ADRs. Then for that we use the smartphone app, which we use in our college also. So in conclusion, we can say we can use the maximum ADR report by the direct patient reporting by the smartphone app or any kind of the new method for that. And this is my reference for that. Sure. We can expect more adverse drug reaction from the patient. The briefly and the errors which are made in that, it could be less in that.
Error could be less.
Yeah.
It is directly.
If they are mainly healthcare professional and that for that help.
Actually, patients are generally, we are supposing that they are non-medical persons.
Okay.
They can explain it.
Mhm.
Okay, what is the problem with that?
Yes.
But if a literate patient is reporting, is that person report accurately to all those
No,
things?
there should be bias also that. Bias should be there.
Bias.
Huh. If
Why bias?
it is if the person is related to the doctor, it can be biased.
So you have mentioned some pros and cons of patient-consumer reporting of ADRs. Can you elaborate on that a little bit?
Yes, so the smartphone app, we can use more ADR reports.
Okay, thank you.
The title of my study was The Study on Medication Errors and Reporting Among Nursing Students. And today is International Nurses Day, so it can be an important topic to discuss today. And the provision and improvement of human health is nurses' primary professional duty. And the administration of the medication is one of the main responsibility of the nurses. And one of the most frequent sort of errors which occur in hospital administration is medication errors. And these account for around 1 lakh hospitalizations per day, according to recent studies. And these are widespread issues, and they can lead. A type of medication errors included were mostly due to the wrong dose and wrong patient. And in the knowledge parameters, I assessed that understanding of medication administration was the most, and the impact of medication error on patient safety outcomes were less. And in practice parameters, due to high workload, there was more medication errors.
Okay. Now, these type of medication errors you have classified for nursing students, right?
Yes, sir.
So what is the basis for that according to you? What do you think needs to be corrected?
These are the five. These can be converted into 5 rights. They can select a right patient, a right medication, right administration, and there should be a right communication between all the healthcare professionals. And
Can you elaborate the wrong medication? Sound alike, look alike. Means you have given the example of
yes, sir.
means sound alike. If that is sound similarly.
Yes, sir.
If that looks like,
Yes.
if you are using a tablet or a vial or a capsule and it looks alike,
Similar.
wrapping is similar, so
Yes.
sometime it may
It
cause
will lead to.
mistake.
Yes, sir.
Thank you.
No, actually, you are talking about knowledge, attitude, and practice, no? That's why
Yes,
I'm
sir.
concentrating on the attitude part. Like any
Yes.
lacunae, there are a lot of lacunae in that type of medication errors, no? Which have been classified.
Yes, sir. In the attitude parameters, there was a more culture of safety in the hospital setup. That if they will report to the concerned doctor or the concerned administration, there can be a conflict over there.
Good morning, everyone. This is my adverse drug reaction case report on piroxicam-induced overlap Stevens-Johnson syndrome, toxic epidermal necrolysis. Stevens-Johnson syndrome, toxic epidermal necrosis is a rare, potentially fatal skin reaction involving skin and mucous membrane characterized with erythematous skin lesion and detachment of the epidermis. 80% cases are caused by medication. My aim of the study is to describe patient who develop SGS-10 following intravenous piroxicam, objective to perform critical evaluation of the reported adverse drug reaction. This case describes a patient who developed overlap SGS-10 after taking intravenous piroxicam for his neck pain. Symptom initially started with fever and rash over chest and back, then detachment of epidermis over back. Diagnosis was confirmed by dermatologist. Supportive treatment was given by immediate discontinuation of the piroxicam. Causality assessment done by WHO-AIIMS causality criteria. As per WHO-AIIMS causality criteria, the association of the reaction to drug piroxicam is probable. SGS-10 can be caused by drug infection, antibiotic, epileptic drugs cause this kind of reaction. This case highlights the potential for SGS-10 to occur as a rare but serious neck pain.
Neck pain. Okay. So it was confirmed by the dermatologist.
Yes, sir.
Okay.
So causality was done by which scale?
WHO-AIIMS causality
WHO-AIIMS
criteria.
scale. Acha. You did not compare it with some other scale?
Here, sir, only.
Acha, what was the classification grade of this?
Classifications are
causality
according
assessment?
to involvement of the body surface area. When less than 10%.
No, as per the WHO,
Yes, sir.
UMC scale, what was the grade? What
WHO
was the
probable,
classification?
sir.
Huh?
Probable.
Probable.
Yes, sir.
Sure, okay. So you are absolutely sure no other drugs were being used in
Yes,
this
sir.
patient or any others?
Yes, sir. It was no, so only piroxicam.
Okay, thank you.
Thank you, sir.
Good morning, judges. Several tools for ADR reporting, like ADR reporting forms, toll-free helpline, and voluntary reporting by non-ADR monitoring centers, and by mobile application. Aim and objectives include to assess the number of adverse drug reactions reported at ADR monitoring center through various ADR reporting tools. It is a retrospective observational study in which ADRs were reported at AMC of a tertiary teaching hospital where they were assessed for the specific tool by which it was reported from January to December 2022. And further, this data was segregated into 4 categories, namely ADR reporting forms, toll-free helpline, voluntary reporting by non-AMCs, and mobile application. Under results, 188 ADRs were reported through various reporting tools in total from January to December 2022. 166, that is 88, know how to use the application. Some even don't know if there is an application for the same. So these are the main reasons.
Okay, so how that can be addressed?
They can be addressed by increasing more awareness through sensitization and training programs, or by using more interventional strategies to make the people aware about this app. Mobile is a very convenient tool and very important.
Because everyone has a mobile phone, right?
Yes, sir.
Almost everyone has.
Yes, sir.
So
Even then, there is a
collection
less
would have
reporting.
been much more.
Yes, it
That
has.
is what I was thinking.
Yes, but there were least reporting was done through the mobiles because of the lack of awareness.
You have mentioned that ADR forms, 166
Yes, sir.
ADRs are reported
Yes, sir.
through ADR forms.
Yes, sir.
From which department you get maximum reports?
Maximum were reported from the Department of Radio Diagnosis, and second one was Department of Neurology.
Radio diagnosis and neurology.
Yes, sir.
Seeing minimum with them from the radiology or neurology, maximum from the psychiatry, skin, medicine, or medicine and allied branches.
So these are the departments which
From where we are,
They do report, but there is much less reporting as compared to radio diagnosis. In our 3 monthly newsletter also, we publish the same, that the radio diagnosis gets the most number of reports for us.
okay, thank you.
Thank you, sir.
Good morning, sir. My poster on pattern of adverse drug reaction reported at tertiary care hospital under Pharmacovigilance Program of India. What is pharmacovigilance? Pharmacovigilance, the science activities relating to detection, assessment, understanding and prevention of adverse effect or any other medicine, vaccine or related problem. Adverse drug reaction reporting is done under the Pharmacovigilance Program of India for patient safety and also benefit to the society in long term. My aim and objective to assess the patient pattern of ADR reported at a tertiary care hospital under the Pharmacovigilance Program of India. Methodology. It is a retrospective observational study for assessing the ADR reported at ADR Monitoring Center of Tertiary Care Teaching Hospital from January to December 2022. Result, total 188 ADR were reported during year from January to December 2022, in which skin reaction like rashes and itching were most commonly 42%.
Okay, while I see the results of your study,
Ji, sir.
one thing which struck me is majority of ADRs belong to type B.
Ji, sir.
What was the reason for that? Any reasons, you know,
Sir,
for the majority of ADRs belonging to type B?
sir, non-serious, so there will be non-serious.
Vaccines,
Sir,
whether it is COVID vaccine or other vaccines.
Covishield,
No,
most
only
common-
COVID vaccines
Sir, hepatitis
or
B.
other vaccines.
Other vaccine, hepatitis B, sir.
Okay, what was the most common adverse effect with vaccines?
Sir, skin and rashes, most commonly.
Skin and rashes. Any other thing? Because mostly we know after vaccination, fever is a very common thing.
Ji, sir.
And you are telling skin rashes.
Ji, sir.
Okay, everywhere at vaccination center, a paracetamol,
Ji, sir.
if the patient is a child or minor, that is the liquid or suspension has been given.
Sorry, sir. Generalized मैंने skin rashes था, वैसे fever है, sir. Vaccine related.
Thank you.
Thank you, sir.
Which comes under the constellation of the Cushing syndrome is ideally associated with more with the use of fluorinated corticosteroids. That is a property, the fluorinated preparations, which deem them to be used for long term and are long acting. And they are used for a long duration, and hence the incidence of corticosteroid-induced myopathy in them is more. But this is a case of a patient with sarcoidosis who was started on tablet methylprednisolone, and within 11 months of the therapy, and it was gradually tapered off. It was initially started with 16 mg dosage, and it was tapered off, and within 11 months, we got the symptoms, the muscle weakness, which was not associated with any kind of atrophy or any kind of other pain, and that was classified. There was investigations which was done to rule out other causes, but it wasn't any conclusive. Venous insufficiency, corticosteroid, so an adrenal insufficiency was also suspected, and for a replacement corticosteroid, hydrocortisone was started, and within 3 weeks of using hydrocortisone, again the symptoms reappeared. It first resolved with the use of after the discontinuation of methylprednisolone, and then when hydrocortisone was started, after 3 weeks of use of hydrocortisone, it again reappeared. So that is why I've termed it as relapse of corticosteroid-induced myopathy.
Okay. So you have seen the patient?
Sir, I have received the patient from the treating physician. The
Okay.
treating physician is a pulmonologist,
Okay.
and he has mentioned to me about, and I have gathered the case, and then I have personally called the patient and taken the other details of the case. That
Patient was taking only corticosteroid or anything else?
methylprednisolone, sir. Initially, the patient
Yeah.
was taking methylprednisolone and sir bisphosphonate so that there won't be any corticosteroid-induced osteoporosis initially prescribed. But the suspect was on corticosteroid.
Any other drug?
No, sir. There weren't any other comorbidities. The patient was only taking these two.
Okay.
Okay, no statin, nothing, huh?
Nothing, sir.
Okay.
Nothing.
Okay, thank you.
Thank you, sir.
Good morning, respected sir. So my poster is on impact of sensitization and training sessions on pharmacovigilance program and ADR reporting in tertiary care teaching hospital. As we know, healthcare professionals are the pillar of healthcare system and are the most important target for the successful implementation of pharmacovigilance program of India, and to encourage adverse drug reaction reporting culture and to ensure patient safety, pharmacovigilance program of India was implemented, and presently there are 701 ADR monitoring center established AMCs. The problem of underreporting still exists, which needs to be addressed for a smooth and proper functioning of this program. And to the aim of this data was collected and compared before and after 6 months of duration of pharmacovigilance week using MS Excel 2.01, and medical and paramedical students, healthcare professionals including doctors, nurses and other paramedicals were sensitized and trained regarding pharmacovigilance program of India and reporting ADR. After that, the data was analyzed for the impact of sensitization and training program on ADR reporting at our AMC, and the results were the data was compared and analyzed before 6 months duration of sensitization and training session held during pharmacovigilance week. There are 103 ADRs were reported, and after 6 months of pharmacovigilance week, 140 ADRs were reported at our AMC.
Okay.
And there is...
Okay, fine.
Yes.
What interventions you took for sensitization and training sessions? What were the contents and how did you structure
So
it?
we went to the wards, clinical wards.
ट्रेनिंग सेशन में आपने क्या किया सर, पूछ रहे हैं?
सर वार्ड में सर क्लिनिकल वार्ड्स में वो पोस्टर प्रेजेंटेशन और जो encourage
What
किया-
was the content of those posters or those presentation?
ओके सर, सर जैसे ड्रग सपोज पेशेंट का वो ड्रग एडमिनिस्टर करे, फिर उसका एडवर्स ड्रग रिएक्शन.
Ajay, you have mentioned in your poster that your target population was for sensitization. Doctors, nurses, paramedical staffs, okay. Any other population required sensitization other than these? Kamre mein baat karte raho. That is useless. So you have to go to the, beside these population, you have to go to the schools, you have to go to the public places where you should do these awareness programs. Okay, thank you.
Thank you.
Good morning, respected sir. The title of my poster is Pattern of Adverse Drug Reaction Reported with Contrast Media in a Tertiary Care Teaching Hospital. So in background, contrast media are used in some cases of CT scan and MRIs to enhance the visibility of specific structures. The two main groups of contrast media are iodinated contrast media like iodixanol, iohexol, and gadolinium-based contrast media like gadobutrol, gadobinic acid, and gadoteridol. Iodine compounds are used in CT imaging, while December 2022 were analyzed. The results was there. A total of 51 ADRs were reported with the use of contrast media between the period of January to December 2022. Itching was the most common ADR reported. That was 41%, followed by rashes, that was 31%, chills was 10%, swelling of face 8%, vomiting 4%, dry tongue 4%, and fever 2%. Now this graph is showing the number of ADRs with different dyes. Iodixanol, 19 ADRs were reported with iodixanol, followed by 12 with iomirod, 10 with iomiprol, 8 with iopromide, 2 with iohexol, but we didn't get any ADR with gadolinium-based compound. No ADR was reported with gadolinium-based compound, which is used in MRI.
Any severe ADR have been seen with have ADR?
So it is in the period of 1 year, it was 51 ADRs, but many CT means it's in thousands. But that only we did the analysis of the ADR which was reported. We didn't compare it with total number of what how much CT and MRI was done within in that year.
No severe ADR is reported?
No, sir.
Okay.
Okay, thank you.
Thank you, sir.
Morning.
Good afternoon, sir. My topic is a case report of ethambutol-induced optic neuropathy. Ethambutol is a first-line medication for the treatment of the tuberculosis. In my case report, 33-year-old male patient taken 5 tablets of fixed drug combination of the isoniazid, rifampicin, pyrazinamide, ethambutol for the spinal tuberculosis, and after 8 months of taking treatment, patient gradually decreased the vision, and the patient is a known case of HIV and on treatment of tenofovir, dolutegravir, and lamivudine since 2017. And for this, tablet ethambutol was stopped immediately, and tablet isoniazid and rifampicin were continued for the tuberculosis, and patient was treated with the tablet zinc, and the recovery status was unknown because patient did not come for the next visit. And on examination, in vision, 1 winter finger count in both eyes, pinhole vision not improved, on tonometer 21 mmHg in right eye and 19 mmHg in left eye. And in OCT, in right eye, retinal nerve fiber layer edema around the disc and with old choroiditis patch between macula and disc, and in the left eye, active choroidal patch in the superior temporal quadrant and the multiple choroidal patch between macula and disc.
In conclusion, sorry to interrupt. In conclusion, you said because optic neuropathy is uncommon. Is it really uncommon with ethambutol?
The antiretroviral drug the patient was taking, you have mentioned fixed dose combination of tenofovir, dolutegravir, lamivudine. Is these drugs causing optic neuritis or not?
Yes, sir.
Huh?
How did you check the causality?
Yes.
And how you reach the conclusion that it is due to the ethambutol. You have written that ethambutol was stopped. After that, patient's condition improved.
Yes, sir. Only 15 to 20% improvement.
Okay.
Thank you.
With the aim of the checking knowledge, attitude, and practice of this about pharmacovigilance in medicals and paramedics, we did this study. So in methodology, we did a cross-sectional survey was conducted to evaluate the cap of healthcare professional and medical students regarding ADR and vigilance with 21 questions which was peer reviewed by expert. So now, as we can see in the result, so we enrolled total 100 participants in this study. Out of 100, the 70 was medicals, and rest 30 are of paramedic students. So as we can see in this paragraph, these are the questions which will be used for the knowledge. So question was like definition of pharmacovigilance and what is the process of pharmacovigilance. So in the conclusion, on average, 62.65% of medicals and 51.42% of paramedics have correct knowledge about ADR. And if we choose the attitude, so medicals and paramedics both have a good attitude about pharmacovigilance.
Devise this questionnaire? I mean, how did you come up with this questionnaire?
Sir, I have seen the 5 to 6 this kind of study, and then we conclude by my faculties, help of my faculties, then we exclude this kind of questions.
How much sample you have taken?
Sir, total 100 samples.
You have taken the medical student also.
Sir, so by medical student we means interns.
As a medical student means
only interns.
Okay. Okay, that's all.
Okay. Thank you, sir.
Good afternoon, sir. Today I'll be discussing respiratory failure as a serious adverse event following dextromethorphan use in children, a case series reported from a tertiary care teaching hospital in Uttarakhand. Dextromethorphan, as we know, is an NMDA antagonist and is commonly used to treat all of the cases presented with clinical features like respiratory depression, 3 of which landed in type 2 respiratory failure, and 1 was admitted to the PICU. All 4 of the cases responded well to the administration of naloxone, and improvement in general condition and respiratory symptoms was achieved within a few minutes after the administration of naloxone. My conclusion is that we need more stringent regulations over the production, prescription, and dispensing of dextromethorphan.
Okay, why you choose this topic?
Sir, in 2021, there was a report in Delhi, in Kalavati Saran Hospital, where 16 children were admitted after ingestion of dextromethorphan, and 3 out of which died. Dextromethorphan is actually not to be prescribed as recommended by CDSCO and below 4 years.
Recently, if you see
sir,
the reports.
In Gambia, there were 300 children who suffered from toxicity because of cough syrup that was manufactured in India. What I feel is that manufacturing...
What was the active ingredient which causes the problem?
Sir, oxy...
No, Gambia and other country also, Uzbekistan. That was one sweetness,
ethylene glycol poisoning, yes, sir.
Almost 66 died in Gambia and 20 in Uzbekistan. Okay.
Okay, thank you.
Good morning, revered judges and audience. My topic of presentation is zoledronic acid-induced lichenoid drug eruptions. The case was presented in my hospital. She was taking zoledronic acid to my college AIIMS, and the case was registered with the AIIMS report number and a worldwide unique number, which is given in my poster. and the upper photographs are showing lesions of the patient in recovery phase, and the middle photos are showing recovered phase lesions, and lowest photos are showing the suspected drug, details of manufacturer, expiry date, manufacturing date, and lot number, and lowest photo is showing my form which I filled for ADR reporting.
Okay. What do you say for the drug name in your title?
What's
drug name in your title? Do you think it is correct? Because at one point
N is not okay. N.
Again, you can check.
Okay, N missed, sir.
N actually doesn't. It's only
Okay, maybe, sir.
Okay. How you done the causality assessment?
So actually, I went through UMC Uppasala criteria, and by that I assessed it as a probable reaction.
Okay. Any other skill do you know by using which you can do the causality assessment?
So at present,
Okay, thank you.
So to which group this drug belongs?
So it is a nitrogenous bisphosphonate, third generation.
Third generation.
Yes,
So did you get some is this a lichenoid drug eruptions a class effect, or
Yes, yes.
or a specific drug effect?
Yes, lichenoid drug eruptions, that is given.
My name is Jahangir Alam, and I'm pursuing PhD in pharmacology from Jain Medical College, AMU, Aligarh. So before came to the this topic, I just want to let you know about that we know that underreporting is the main factor for the regulation of the Material Vigilance Program of India, and as well as Pharmacovigilance Program of India. So we have actually designed or research PhD project on Material Vigilance Program of India. So I had literature that showed showed the underreporting is the one of the major factor that is complications and the constant in the reporting of the medical device adverse events. So in this we made actually a questionnaire there. There are 10 questions that concern with material vigilance particularly, and these questions we asked from the physician and the JRs and SRs they are working, and we found that 90% of the doctors and the SR and JRs actually don't know about the material vigilance. So I think that is the main factor that is becoming a constant to report the adverse events of the medical devices. So it could be a good presentation for to help in reporting the medical device adverse events. If we present that MDAE reporting form in all OPDs. Thank you.
What?
Moderate and high risk respectively. So like the medical devices like hip implants, cardiovascular implants, eye lenses, and other medical devices are there that can be reported.
My question to you again is how did you develop this questionnaire? What was the method you used?
Actually, sir, I was also literating for my PhD research proposal. So I found a paper that was very precise and fine about the survey regarding the reporting culture of the medical devices. So it was from, I think, AIIMS book that we can ask to the physicians regarding the material vigilance.
Thank you very much.
Thank you, sir.
Good afternoon. This was prospective observational single-center study conducted with the aim of to evaluate the adverse effect of hypnotics on memory and psychomotor function. After taking institutional ethics committee permission, all the patients who newly diagnosed and who can read or write Hindi, Gujarati or English were enrolled in this study. Total 30 patients were enrolled. Out of them, 2 were lost to follow-up. Most common that 10 patients had zolpidem, 9 patients were on clonazepam, and 9 patients were on lorazepam. Most common pattern seen was sleep onset insomnia. In that patient had increased the sleep latency. Majority, 75% patient had short-term insomnia. In that they have symptom for 1 month to 6 months. This table shows all the significant results. Much for attention and concentration was significantly worsened at 4 weeks as compared to baseline, as well as at 2 weeks. Delayed recall, immediate recall, recognition, single letter cancellation was significantly affected at 2 weeks and 4 weeks as compared to baseline. And total PGI score, hand steadiness, was significantly worsened at 2 weeks and 4 weeks as compared to baseline, as well at 4 weeks as compared to 2 weeks. So we conclude that there should be memory and psychomotor function should be evaluated periodically in patients on hypnotics. These all are my references. Thank you.
Okay, the question that I have is, study duration is for 9 months,
Yeah,
right?
9 months.
How did you choose that study duration?
So study duration, we decided that all this duration, the patients come in, it is pre-decided that we will do this study for 9 months in OPDs, psychiatric OPDs, newly diagnosed insomnia patient who came for that. And that only only hypnotics. All the other medications like antihistamines and statins and all the psychiatric medications, only hypnotics, pure hypnotics.
Pure hypnotic patient, you will get only 30 patients.
Yeah.
In 6 months or 9 months.
Yeah, 9 months, 30 patients.
Only 30 patients.
Yes. So purely.
No, the ideal is that you should fix the patient. Sample size is very low.
Yeah.
If you see the
this study is still going on. This is one that interim of that my study. Study will
by using 30 patients in hypnotics.
Yeah.
Which is very commonly used. It is not a substantial number to reach the conclusion.
Yeah. So sample size is low. We cannot measure in between that groups of whether lorazepam or clonazepam or zolpidem, which is better. We cannot conclude that with this sample size. But this is that one interim of my study, week and then 4 weeks.
After which duration there is a chance of memory and psychomotor function
impairment. 4 weeks, sir. These
Within
all the
4
parameters.
weeks.
These parameters were affected.
Okay.
We that measure using repeated measures ANOVA. So
Okay, thank you.
Very good afternoon. The topic for the presentation is fixed drug reaction due to ceftriaxone, a case report. Here, male patient, 85 years old, came to the chest and TB department with the complaints of shortness of breath and cough with sputum, fever with chills, and the loss of appetite for the past 5 days. Patient was a known case of old treated, which is a third generation cephalosporin at a dose of 1000 milligrams twice a day. And on day 4 of IV administration ceftriaxone, patient started complaining of itching and a bluish patch over his left forearm and over the left leg. So after which the ceftriaxone was stopped immediately and the dermatological reference was taken, where they advised to take the alternative medication, antibiotic for that, and to take cetirizine and to apply calamine lotion. So the case presentation along with the dermatological reference concludes that this drug reaction was possibly due to the ceftriaxone. And I conclude my presentation with the note that such fixed drug reaction should be taken into consideration and should be a proper diagnosis or management should be done immediately to avoid the further complications. They are rarely caused of fixed drug.
If ceftriaxone is causing fixed drug eruption, in my view, amoxiclav should be avoided.
Should be avoided.
If you have give the amoxiclav, I think
that's what we have
that
recommended.
also produce the same thing.
We also recommended them that you should not start the amoxiclav along with that.
No, you have said that.
But they have started on that. So.
In such cases, the reconciliation has to be done, you know,
Yes,
in a very structured way, huh?
Yes,
with a lot of deliberations.
Yes,
okay, thank you.
Okay, thank you.
Thank you so much, sir.
Good afternoon, sir. Here I present a case report of depth-induced methemoglobinemia. Methemoglobinemia is a two type, acquired or inherited, and acquired methemoglobinemia is the most common. Here a 64-year-old female patient was diagnosed with generalized bullous pemphigoid, was taken prescribed a tablet depsone, increased to 9 to 10 liter per minute, and the saturation was increased to 95% saturation. The also is given the PEG cell volume to increase the hemoglobin level and the vitamin E and vitamin C for 4 days. Her laboratory investigation shows the methoglobin level 3.4% and the arterial blood gas analysis was within the normal range. And the patient condition were improved after 4 days, and the causality assessment include WHO and Naranjo as a probable, and the severity for the level 5 because the patient is admitted in the ICU and is also given the BiPAP support. And the modified Kumler and Thornton is the preventable due to the treatment is available. Thank you, sir.
Okay. Any other condition which can produce methemoglobinemia?
Yes, like other drugs, metoclopramide.
No other questions from my side. Thank you.
Thank you, sir.
So,
this was P28. Okay, so these two are absent. These two people
31 and 32.
absent. Totally you can do it, right?
So we have come to the end of offline poster presentation. I would like to thank our dear judges for sparing their valuable time with us. Now I request Dr. Manisha Bisht to felicitate Dr. Atif Beg.
Sir, Dr. Atif Abdiya ji, sir ke saath we'll have all our volunteers. यहीं पे देंगे? सर आप लोग बीच में आ जाइए, we'll stand.